All right, let's walk through this case together. We're looking at an MRI of the brain, and the findings are quite striking. There's high T2 and flare signal involving both medial temporal lobes, more pronounced on the left than the right, as well as both inferior frontal lobes. These areas also show sparing of the basal ganglia, which is a useful observation. Adjacent sulcal effacement suggests some degree of mass effect. The high signal extends superiorly around the rostrum and genu of the corpus callosum, which is an unusual but telling distribution. On T1-weighted imaging, these areas correspond to low signal, consistent with edema. Importantly, there's no evidence of a surface collection or hemorrhage. The sinuses and mastoid air cells are normally aerated, and intracranial arterial and venous sinus flow voids are preserved, ruling out vascular causes. There are also signs of generalized cerebral atrophy, which may reflect the patient's baseline or chronic changes. The ventricular system, CSF spaces, pituitary gland, and visualized cervical cord all appear normal. Now, interpreting these findings, the high T2 flare signal with corresponding low T1 and mass effect strongly suggests cerebral edema. Given the clinical history of fever, this pattern is highly consistent with an infectious process, most likely herpes simplex encephalitis. The medial temporal lobe involvement and extension into the inferior frontal lobes are hallmark features of this condition. Differential diagnoses to consider include other causes of viral encephalitis, such as EBV, varicella zoster, or influenza. Limbic encephalitis is another possibility, particularly in patients with a history of malignancy or paraneoplastic syndromes. Status epilepticus could mimic some of these findings, but there's no clinical mention of seizure activity. MCA infarction is unlikely given the bilateral involvement and the sparing of the basal ganglia. So what's the next step? Clinically, this is an emergency. I would call the referring clinician immediately and recommend starting intravenous Acyclovir without delay, as timely antiviral treatment is critical for herpes simplex encephalitis. A lumbar puncture for CSF analysis should be performed to confirm the diagnosis and exclude other infections. A neurology consultation is also warranted to guide further management. From a radiological perspective, I'd review other MRI sequences, particularly DWI and ADC maps, to look for restricted diffusion, which can further support the diagnosis of herpes simplex encephalitis. In summary, the imaging findings and clinical context point strongly toward herpes simplex encephalitis, a diagnosis that requires urgent treatment. This case highlights the importance of recognizing key imaging patterns and acting quickly to improve patient outcomes. If you find these case reviews insightful and want to learn more, don't forget to subscribe to Radiology Made Easy. Turn on notifications so you don't miss any updates, and good luck with your studies and exams.